Good afternoon here in California. My name's Stephany. I am one of the pediatric urologists at the Children's Hospital of Orange County and the University of California, Irvine. I have been involved with IVUmed since 2014 and have essentially been taking trips twice a year with the team doing reconstructive workshops and pediatric workshops. Unfortunately, but I've only been to Africa so far, and I would love to go other places. So I know we are all very excited to start traveling when it's safe again. But today, I wanted to talk to you guys a little bit about pediatric urologic trauma and emergencies. And I don't know how much of this you guys see. And if you think of questions throughout, you can either put them in the chat box, or Katie, I don't know if there's something else you guys do for that. Happy to do whatever works for you. We can just save them at the end, or feel free to ask a question anytime during the presentation. Okay. Okay, so first today we're going to just kind of look over the diagnosis and management of the GU trauma system. So we're going to start with upper tract of kidneys and ureter, and then we'll hit lower tract with bladder, urethra, and genital. And then I always like to give this talk to my residents and kind of do a practical applications for kind of the consults they may get when they're on call. So I always like to start with this too. A lot of the residents, when they come on service, they've never done pediatrics of any type. And I always remember them, kids are not little adults. There is physiologic and anatomical differences, as well as developmental differences. So this is something they have to always kind of think about. We can't just keep treating them like they're adults, especially in a trauma situation. Kids are very much able to compensate much more better from such as blood loss. They can actually have normal pulses up to and normal blood pressure up to almost about 40% of a blood loss. So as I tell my residents, when kids crash, they crash hard and it comes fast, but it can take a while. They have very rapid deterioration, but they are able to compensate much better than adults. So that's always something to keep in mind when they're seeing patients and they say, oh, but everything's fine, their blood pressure is fine, and their heart rate's fine. But I say you always have to think about the mechanism and what you're looking at as well. And so I just have on reference at the bottom of this slide, just some normal values to always kind of keep in the back of your mind. My residents always freak out when they come on the pediatric service and see a normal, see a heart rate of 100, and they tell me every morning on rounds that they're tachycardic. I said, no, they're just little, they're kids. This is normal for them. So just something to keep in the back of your mind. Blunt trauma is the most common thing that we see, and 90% of traumas in the pediatric realm for urology are blunt trauma. So we're talking falls, car crashes. Now, most of these kids, if they do have a urologic trauma, they'll usually have something else going on too, such as spine, rib fractures, pelvic fractures, and hematuria is not as reliable in assessing the location and the severity of the injury. We teach this in the adult world too, but it's even more so in the pediatric realm. So as we talked about, falls, motor vehicle crashes, and actually one of the more common things that we see over here in the States is ATVs or all-terrain vehicles or four-wheelers or whatever they may be called are such a big risk for infection, for trauma. Bicycle crashes, and actually equestrian and downhill skiing, which Katie and I were just talking about, can be a high risk for renal injuries. Penetrating injuries, obviously gunshot, knife, and falling on objects as well. So the AUA put out guidelines in 2014 and then updated them in 2017 about Eurotrauma guidelines. Now, I caution you, these are not pediatric specific, but fortunately, trauma is one area where pediatrics and adult are not too significantly different. Obviously, there's some definite things to remember, but in terms of guidelines, it's fairly reasonable to kind of follow along with this. So first and foremost, you want to make sure that you have accurate and efficient radiographic evaluation. You want to try to preserve GU function whenever possible. And you want to be familiar with both open and minimally invasive techniques for hemostasis and urinary drainage. You obviously want to make sure you've got the right diagnosis and the right intervention. And then don't, remember the entire system. I think a lot of people just think of kidneys, but forget about a lot of the other GU systems. So the European Association of Urology actually did put out renal trauma guidelines in 2020. And a lot of these recommendations are very similar to the adult AUA guidelines. And so we'll go over this in more detail. So the majority are secondary to blunt trauma when we're now starting to talk about kidney trauma. And renal injuries occur in 10 to 20% of blunt abdominal trauma. The pediatric kidney is thought to be more susceptible to injury for a couple of reasons. Now, whether or not this is exactly true is hard to know. There's been literature supporting it and literature refuting it. But it's thought that, and it makes sense intuitively, that the kidneys are protected by an immature, very much more pliable rib cage and thorax, and they have weaker abdominal muscles. The kidney is also larger in a child relative to the rest of their body. And they also usually, although US kids can be somewhat chunky, they usually have less perirenal fat, and the kidney can sit lower in the abdomen. You also have to remember there are congenital abnormalities of the kidney that need to also be in the back of your mind. So those are 3 to 5 times fold more common, such as hydronephrosis, especially if they have a ureteropelvic junction obstruction. And so we want to, I think the key here is being diagnostically aggressive and surgically conservative when it comes to renal trauma in kids. This also is now true for adults as well, but time is key. First and foremost, don't forget your ABCs in trauma. So you want to assess hemodynamic stability, airway, breathing, circulation. A good old-fashioned history and physical is so important. Do an exam. Do they have bruises? Do they have flank swelling, hematoma? The mechanism is important because that may tell you what imaging you should get. You also want to look at if they've got hematuria, obviously a urine analysis. So look for gross hematuria and microhematuria. But just remember, there's poor correlation with hematuria and renal injuries in kids. So a lot of kids, almost 2/3 with a grade 2 or higher injury, will have a completely normal urine analysis. Then lastly, remember hypotension and the degree of injury. A kid has a much higher sympathetic tone and can have a normal blood pressure even though they've lost a lot of blood, like we talked about previously. So they can lose a lot before they all of a sudden hit their hypotension level. In adults, if they are hemodynamically unstable and they have hematuria, you do imaging. For kids, all penetrating abdominal and pelvic trauma, you would want to do imaging, which we'll talk about what kind. Now, when you have a blunt trauma, if they have the type of injury is a significant deceleration or high velocity, such as a motor vehicle crash or falling from a high level, like 15 feet, or they are struck in the back with a foreign object, that is something to think about and to probably go ahead and do imaging. Also, if they have significant spine, pelvic, or rib fractures, or any bruising of their torso or signs of peritonitis, you'll want to do imaging. Gross hematuria in a child, you'd want to do imaging. Now, microhematuria, and this goes for adults too, but greater than 50 RBCs on a microanalysis, or greater than 5 RBCs for a penetrating wound, and also adding shock. Now, again, remember with kids, the blood pressure systolic blood pressure in a kid less than 90 may not be as something significant as you see in the adult world. So the standard the most sensitive test and the classic standard is a triphasic CT scan, and you must have delayed imaging. I don't know how it is there, but here it is such a struggle. They always forget delayed imaging in the pediatric realm. And without having a drainage film, you really might miss either an isolated ureteral injury or a urinoma or a grade 4 or 5 renal trauma just because of with a urine leak. You do want to look at if that ipsilateral distal ureter has contrast in it, because that actually may predict who may need treatment or who may not and could just be observed. An intravenous pyelogram is not sadly done very much here in the States, but they still always test about it on our boards. And a single shot IVP in an unstable patient who's taken immediately to the OR can be a very big value. And the injection is 2 milliliters per kilogram of contrast. And you want to get your abdominal x-ray 10 to 15 minutes after the injection. I'd be interested to hear what you guys do for your imaging. And then they're really trying to push more ultrasound for traumas to assess, and it's called the FAST exam, to see if there's any blood, free fluid, or anything like that in the abdomen. And a lot of times they're trying to get away from obviously doing CT scans in kids, because we really want to try to adhere to the Alera principle with lowest amount of radiation as possible. But a fast ultrasound can be done and can be used sometimes in conjunction with observation, as well as labs and a physical exam. So this was a study where they actually, and this is a big push, as we all know, we don't like to do CT scans in children if we don't have to. So this study looked at ultrasound to evaluate blunt renal trauma in kids, and they were comparing this retrospectively, mind you, to CT imaging. So 76 patients were reviewed, and ultrasound had a sensitivity of 79 to 100% and a negative predictive value of 97 by 4 blinded reviewers. So what they found was that ultrasound may be sufficient to rule out a clinically significant trauma. Now, grade 1 and 2 injuries were frequently missed on ultrasound. So, in the presence of gross hematuria and microhematuria with greater than 50 were present in all grade 3 to 4 injuries. So again, always remember, even if they don't have gross hematuria, make sure you're checking a urine analysis with micro, so you can look at how many RBCs are there. So I should have probably put this first, but let's go back to our grading of renal trauma. So you've got grade 1 right here with a subcapsular hematoma and or contusion. There's no collecting system injury. Grade 2, the laceration is less than 1 centimeter into the cortex right here. Small hematoma, but all contained within Gerota's fascia. A grade 3, greater than 1 centimeter in depth and can go into the medulla. The hematoma is still confined as well to Gerota's. And then when you start talking about a grade 4, you've got urinary collecting system extravasation, or you could have renal pelvis laceration or a UPJ disruption, or a vascular segmental artery or vein could be injured. Now, a grade 5 is typically described as a shattered kidney, is how we were always taught. But this could be a main renal artery or vein, avulsion or laceration, or even a clot. So this is just a CT representation of what we're talking about here. Here's the left kidney with a hematoma here, but nothing going into the cortex for our grade 1. Grade 2 here, a little more difficult to see with a small laceration here, but then we've got our hematoma as well. And then a grade 3, which is more than a centimeter here into the cortex. Grade 4, you can see this is a delayed film, and here is contrast extravasating out of the collecting system. So this is why, again, you have to have those delayed images, because if you don't, you can certainly miss this. And then a grade 5 here with the kidneys just kind of, here's the normal kidney, here's the not so normal kidney there. So how do we manage it? Usually immediate surgical intervention is needed in less than 10 to 20%. Most of the time we can watch this. Now, there are a couple of reasons not to. Obviously, if they're unstable, then you are going to be forced to. If they're going back to the operating room for other issues, then sometimes you are called in, and sometimes you're not called in and they already removed the kidney when the kidney could have been saved. So 25 to 50% of high grade, so grade 3 to 5 renal injuries can be managed non-operatively initially, but some will go on to require some type of intervention. That could be as simple as ureteral stenting or nephrostomy drainage. And this could be needed if they have more extravasation or they become symptomatic with their urinoma, such as fever, flank pains worsening. And then I think what we have that is very nice, and I still think very underused, is angiography and selective embolization by our interventional radiology folks. I've seen a couple of kidneys saved simply by doing this, which has been really nice. So absolute reasons to go to explore if they are unstable hemodynamically, and that can be seen in the grade 5 renal vascular injuries. If they're back there and they have an expanding or pulsatile retroperitoneal hematoma, then you would want to explore. A lot of times, again, that's when you get called in by the surgeons and they'll notice something back there. And if it's expanding or pulsatile, then I may go in there. If it's not, and I know what the imaging has shown, that I'm not going to poke any skunk, so to speak. Or if they've got a persistent or delayed hemorrhage that you could try to do by vascular embolization first, but if that doesn't work, then you would need to take them back. And most of those are going to result in the kidney removed. Other kind of grayer reasons of why to go back is if you do find a retroperitoneal hematoma when you're exploring for intra-abdominal injuries. Again, if it's not pulsatile and I have imaging already and I know that the other kidney is healthy, I'm going to probably try not to do anything if it's not pulsatile or expanding. Also, if you've got CT documented high-grade injury with other intra-abdominal injuries, again, that's controversial, and I think a lot of times when you do that, the kidney's coming out. I don't know how it is there for you guys, but a lot of times our general surgeons are the first call for pediatric trauma, and a lot of times they will just remove a kidney. I think we have a great relationship with our pediatric surgeons here, and so they call us all the time for this. So we try to really preserve every kidney unit we can. What do we do if we're not going to explore? Well, we'll get them admitted to the hospital and we'll do exams. We'll also do hemoglobins every 6 hours or 8 hours, depending on their levels and the vital signs. We also check their urine. Obviously, we would transfuse as needed. I typically say stay on bed rest until their gross hematuria resolves. Now, in the adult world, I feel like we always put a catheter in. In kids, if they're voiding okay and they're emptying okay, then we often won't put a catheter in. But if we are concerned about a grade 4 injury with urinary leakage, then oftentimes I will put a catheter in to make sure we're maximally draining. You want to look for those signs of a symptomatic urinoma, such as flank pain, ileus, fevers. I will typically start them on prophylactic antibiotics to prevent seeding of a urinoma. And then usually follow-up imaging 2 days later may be needed, especially if we're seeing symptoms or becoming unstable. So a couple of different studies have also looked at CT predictors to know when and when not you have to intervene. So some of the things that were more likely that needed intervention were perinephric hematomas that were larger than 2.5 centimeters. So in those cases, those a lot of times you could try to do with angiography and embolization. If they had evidence of an active bleed on CT scan, like where you can see the actual blush, you would want to maybe send them to interventional radiology for embolization. If there is lateral extravasation of contrast with no contrast found in that same distal ureter down by the bladder, those are more likely going to require a stent placement. Hopefully, if that's what you can do, and get a stent in cystoscopically, or sometimes open exploration. If they have medial extravasation of contrast, they also would likely require stent placement or open exploration. So other studies, and this is one that came out of where I used to work in University of Pittsburgh, grade 4 renal trauma. They looked back at their series from 2000 to 2007 and had 17 patients. And the patients that ended up needing intervention were those that had no contrast seen distally on that side of the injury, a large separation of the poles of the kidney, if they required multiple transfusion and had multiple areas of extravasation. And of those, they had a 47% intervention rate. So this is actually an 11-year-old boy I took care of last year who had quite the bike crash, and he fell on his handlebars. And you can see here his right kidney. Here's the right ureter. There's a nice right kidney with the delayed imaging here. And now here's his left kidney, which is, you can see that he's got, here's his upper pole and his lower pole. And he has a nice big hematoma right in the middle there. So that was already one of those that we said would potentially predict needing something. And then here, when you're looking at the delayed images, I'm looking to see if I can see his ureter distally, and I can. So I chose in this child to wait and not do anything and watch him. We placed a catheter. He was on bed rest. His hemoglobin was stable, but I felt since I could see this contrast down here. Now we did have this polar distribution that could have pointed me the other way. So I watched him. Now on day 3, he spiked a fever and started having more pain. So at that point I said, okay, we failed conservative management and now it's time to take him to the operating room. So my goal, I went in with cystoscopically and performed a retrograde pyelogram, and you can see here's his upper pole calyxes and his lower pole, and then right here is where the injury is and the extravasation here. This was a very, very difficult stent placement. I think I probably went through about 3 different stents, but I finally got the stent to go in the renal pelvis, which was extremely small at that point. But here you can see the extravasation of the contrast. And here's his ultrasound. I always like to get an ultrasound at the time of after the CT scan even, or just to have a baseline when they're in the hospital, because I don't repeat CT scans unless I need to when I follow them up. I just repeat them with ultrasounds. So here he is a year later, and I told him it looks like a heart, but you can see his upper pole and his lower pole, and then this kind of area right here where his injury occurred. But overall, the kidney looks beautiful. Now his blood pressure is a little bit higher than it should be for a 12-year-old. So I sent him to our nephrologist as well, just to make sure. So remember, kids can have congenital issues such as hydronephrosis and urinary pelvic junction obstructions. So you have to be sure that if they had a trauma, which I've had one kid, he was surfing and a surfboard hit his back and he had a UPJ that was unknown about and he ruptured it. So the vast majority of these kids will have a grade 1 injury actually. So it's not even, it's just a hematoma, but it'll go right through the dilated pelvis. When you see extravasation, the most commonly rupture, it's the renal pelvis through a very thin cortex. If you do see extravasation, a complete UPJ disruption is rare. And there are 3 classic findings you'll see on a CT scan: absence of parenchymal laceration, medial extravasation of contrast, as well as no visualization of that ipsilateral distal ureter. So what is the follow-up? I like to do ultrasounds. Now this is a lot different than adult world, but for grade 1 and 2 injuries, follow-up and imaging is not recommended. For grade 3, with viable fragments, they recommend an ultrasound at 3 months post-injury. If they have devitalized fragments, they would recommend a CT or MRI. In grade 4 or 5, obviously, they would recommend a CT scan. I still will just do ultrasounds unless I'm concerned that a hematoma is worsening or things look worse on ultrasound, then I would get a CT scan. You'd want a UA and blood pressure at 6 and 12 weeks post-injury. And then you can always do a renal scan if there's concern for the long-term prognosis of that kidney and or if they have hypertension. So speaking of hypertension, that is one of the things that we obviously want to follow, because trauma-induced hypertension can usually develop within 3 years or so. If it's sustained, again, you can do a renal scan. And if the renal scan shows less than 20% function of that kidney with hypertension, then you could do a nephrectomy, and that might help with the hypertension. You may need an MRI or CT angiogram to rule out an AV fistula or a pseudoaneurysm. If they do have that, you can treat that with embolization. And then also, some of these guys or girls will have chronic flank pain. And it's very low percentage, about 7% in a grade 3 or more. Usually there's really no specific cause. I had one patient who had chronic flank pain and he had a chronic hematoma that just really never kind of decreased in size. And so actually he had this assist decortication, so to speak, and actually improved significantly. So in some, you may even need to do an nephrectomy, but I would be very, very weary of operating for pain. I was always told don't operate for pain because it may not get rid of the actual problem. So in summary, imaging is crucial. We've got to get imaging and we've got to get delayed film so we can truly see the full urinary system. There are absolute and relative indications for exploring, but the majority of renal injuries can be managed expectantly. 95% of clinically stable patients with grade 4 managed non-operatively will not require an open procedure, but they still may need some type of endoscopic procedure, and most will have a clinically functional kidney. So this is kind of my resident slide that I always like to tell them. We have to have delayed imaging. It is necessary. Now, what happens is a lot of times these kids come from other hospitals where they don't do it, but they've already done a CT scan, and I don't want to repeat a CT if I don't have to. So one thing you can do is if they've already had their contrast, you can do an x-ray, just a plain film x-ray when they're at your hospital to see if there's extravasation, because that's still taking time to get through the body. Obviously, it depends on timing. You want to check the UA. Do not forget the UA. Don't forget about your interventional radiology friends, because we really do try, especially in the pediatric world, to save any and all renal function that we can. If needed, and there's no time to get any imaging before the operating room, remember the on-table intravenous pyelogram. You want to get a shot at 1 minute and then at 10 minutes and do 2 milliliters per kilogram for peds. Remember, the blood pressure greater than 90, ideal for an accurate study. So this is just something they always ask us on our board exams, even though we really don't do it in practice. I always say don't open the retroperitoneum unless it is enlarging or pulsatile. But if I get called in and I look back there and nothing is yelling at me to do anything, I do less is more. And then all my patients always ask me if their son can play football with one kidney. And I always answer, well, you can play football with one brain. So I will leave it up to them if they would like to play. But there are flank guards and other things that they can do. And I also tell them that football really isn't the biggest source of kidney injuries. It's more things like the recreational vehicles and equestrian and skiing. So ureteral injuries alone are very rare. They're less than 4% of penetrating injuries. These will typically occur with other abdominal injuries, such as renal or bladder. These can be iatrogenic, from open surgeries, laparoscopic, endoscopic surgeries. Ureteroscopy is actually the most common cause in the pediatric population for iatrogenic injuries. You have to have a high clinical suspicion because hematuria is really unreliable, and you would diagnose these typically with a CT scan or a retrograde ureterogram. Contusions can be caused from a gunshot wound or a crush injury. So if you notice this, then stenting it early would be great. If not, nephrostomy tube, and then you can always do a staged reconstruction if it's not noticed right away. If it's a gunshot wound and high velocity, you can see a delayed urine leak from tissue necrosis. So you may not know that this was actually hit. If it's near the ureter when you're exploring, you can always consider stenting. And then iatrogenic, it depends on the location. So if this is high up, you could do a ureteropilostomy or a ureterostomy. If it's mid, you can do a ureterostomy or even a trans UU. And then distally, you could always reimplant a psoas hitch or Biore flap. So once again, as I tell the residents, don't forget the ureter. It's oftentimes forgotten. And is the patient going to the operating room when they call you? And that's what I always like to know, because if they are and they're stable, then you can primarily repair it at the time. You may need to do maximal drainage, so not even just stenting. Sometimes you need to also put a catheter in to really maximize everything. Always kind of have this in the back of your mind when there's a delayed presentation of flank pain, abdominal pain, a prolonged ileus, the BUN and creatinine starting to increase. If they have a drain, sending it for a serum creatinine to see what it is, persistent nausea or vomiting, and then always ask about previous surgeries. So now we're moving down to our lower tract, and bladder injuries are actually rare in pediatrics. Less than 2% require the operating room. It is more susceptible, surprisingly though, than the adult bladder because it's higher position in the abdomen, especially when full. So then you can see the intraperitoneal rupture. There's less muscular protection by the abdominal wall, and there's less pelvic and abdominal fat typically. Usually this is associated with multi-organ trauma, and it's less associated with pelvic fractures as compared to our adult population. The mortality rate can still be quite high at 20%, and it's mostly a blunt trauma. When do you need to image for this? Well, absolute indications: gross hematuria with a pelvic fracture, or if they cannot urinate. Other possible needs: urinary clot retention, perineal hematoma, or a history of prior bladder augmentation. So you need to differentiate ultimately between intraperitoneal and extraperitoneal because that really affects the management. So the gold standard for diagnosis is a CT cystogram. Now that sometimes can be hard to do, or if they've already had a CT scan, you don't necessarily want to repeat another CT just for your cystogram. So just doing a cystography can be definitive. And you'll want to use contrast instilled by gravity via Foley. And we say we want to use at least a half of the bladder capacity. So in pediatric population, you want to do their age plus 2 times 30, and that will give you the milliliters or cc's that you need to get to half a bladder capacity. You need to make sure that you get a post-drainage picture, AP, oblique, and lateral, and post-drainage, because you could still miss a bladder injury if you don't get the post-drainage. If there's a urethral injury present, then you could have a suprapubic tube placed, and you can do this that way. You may not see extravasation if there's a clot that is occluding the perforation. So here's some examples of extraperitoneal bladder injuries, which are the most common and a lot of times can be managed conservatively with a catheter. So 85% of these are associated with a pelvic fracture. And you can see here this extravasation right here, and then kind of the teardrop deformity they always discuss, and that's usually because of a pelvic hematoma compressing the bladder. Here's just an example of the CT cystogram showing you the extravasation here. And then intraperitoneal, this is when you're going to see the contrast outlining the bowel. A lot of times in a transurethral resection of a bladder tumor, you'll see the extraperitoneal. If you make a hole in the bladder, you'll see extraperitoneal. I always fear doing those surgeries in intraperitoneal because of those you need to go explore them. So these can be more commonly seen when you have an increase in the intravesical pressure from a sudden blow to the abdomen pelvis. Remember, if you have a full bladder in a kid, it's going to be sitting a lot higher. The dome is the weakest part, and that's right on top of that peritoneal surface. This again shows the outlining loops of the bowel. These are usually associated with severe intra-abdominal injuries. And if they place a catheter and there's no urine bag, you want to consider an intravesical rupture or intraperitoneal. So again, how do you manage these? It's going to be determined by, is it blunt or penetrating? Is it going to be extraperitoneal versus intraperitoneal rupture? So surgery indications: all penetrating bladder injuries, all intraperitoneal bladder injuries, and extraperitoneal bladder injuries. If there's a bladder neck injury, now be careful because you can have high incontinence rates afterwards. If there's a vaginal or rectal injury, or the catheter is not draining secondary to clots, or maybe a bony spicule into the bladder. And intravesical, all must be surgically explored and repaired. You can have metabolic disturbances from this. You can have peritonitis. I had a kid who had a laparoscopic appendectomy, and the trocar went directly into the bladder, was removed. He was sent home after surgery. He had never urinated once after surgery. Came in with a sodium of 123. The injury was through and through the bladder, so we had to take him back. Did a 2-layer closure. We put a suprapubic tube through a separate wound and away from the trigone, and then to try to help avoid any fistula. Extravesical, even though they may have a significant amount of extravasation, doesn't really correlate with the size of the laceration. So a lot of times you can be fortunate to just place a catheter for 7 to 14 days, and then before you remove it, you'd want to do a cystogram to make sure it's healed. So always ask about prior surgeries. As I discussed the trocar injury, ask about any other injuries. Does they have pelvic injuries? Because that would make you more inclined, rectal, vaginal. Are they going to the operating room? If they are, you might just take a look in there. Is there a catheter in? Was the bladder imaged appropriately? Do we even have all the facts? If they haven't had a CT, make sure they get a CT cystogram. If they have already, which they probably have, then a cystogram with post-drainage films is appropriate. Now, urethral injuries, fortunately, this is less commonly seen in the pediatric world because this is fairly well protected. The elasticity is protected, the shape, but you do need to consider this with a pelvic fracture or significant trauma to the perineum. So signs of urethral injury: blood at the meatus, gross hematuria, pain during voiding or unable to pee, or perineal swelling or scrotal swelling. The mechanism is important. Doing a digital rectal exam can sometimes give you an idea, but it's sometimes difficult to do in the pediatric population, which we oftentimes don't. You want to look at a urine analysis, and imaging is warranted if you have the triad of perineal or genital hematoma, blood at the meatus, or an inability to void. Those kids have to be imaged. If you have a fracture of the pubic rami or diastasis of your pubic symphysis from blunt trauma, you also want to consider a urethral injury. So in boys, we'll do a retrograde urethrogram, and in girls, we suggest a CT scan or an exam with a cystovaginoscopy. So posterior and anterior urethral injuries are also treated differently. This is also very controversial in the adult world as well. So prostatic and membranous urethra, including the urogenital diaphragm, most commonly it's the membranous urethra, and that's most commonly associated with pelvic trauma. Significant complications from repairing posterior urethral injuries are strictures, incontinence, and erectile dysfunction. This is where some camps say you fix right away, others say you divert with a suprapubic tube and come back later and fix. Anterior urethral strictures are more of what we think about in the pediatric world, a little more with straddle injuries, or in adults too. But the bulbous and penile urethra, a lot of times you can just place a catheter if you can get it past that and it can heal. But immediate treatment would include antibiotics, assessing the bladder neck competence, and urinary drainage. So again, for the bulbar and penile urethras, a lot of times just catheter drainage is all you need. For females, you'd want to, if they're stable, do a nice exam while they're asleep and do a primary repair. If they have more significant injuries, then they may require some type of diversion of their urine to hopefully let things heal, come back later and do a repair later for continence. So always ask, is there a catheter already? Has the patient urinated? What is the urine analysis? And have you had a retrograde urethrogram if there's concerns? I always say do it yourself. Our radiology residents are typically the ones doing it because it's the middle of the night and they may not have a clue on how the best way to do this is. If a catheter is already placed and you're concerned still, you can always put a tiny little, little tiny feeding tube right next to the catheter and do a pericatheter rub, and that would show you extravasation as well. When in doubt, you can do a cystoscopy and scope the catheter in at the bedside. We're fortunate that we don't have to do that a lot in pediatrics. One, because we don't see a lot of it. Two, in kids, we're going to be taking them to the operating room to do a general anesthetic. In the adult world, you can scope the catheter in at the bedside while they're awake, which is very nice. So if they're going to the operating room and you're concerned, just go ahead and put a camera in and you can take a look at it. Now, this was one of my partner's patients, and this little unfortunate guy fell on a pencil here. And he was so fortunate that it did not injure his rectum or his urethra or scrotum. Next, we've got scrotal and testicular trauma. So penetrating traumas we commonly see with dog bites. You always want to make sure there's no urethral or rectal involvement. You'll want to check for their tetanus immunization and rabies status of the animal. Blunt trauma, falling, sports related, a lot of baseball guys, if they're not wearing cups, or lacrosse, you always want to make sure too that the testes are not involved. A trauma can also mask the true cause of pain, which could be torsion. So anytime a guy comes in with scrotal testicular pain, they need to get an ultrasound. You'll treat them with broad spectrum antibiotics, and if it's an open wound, irrigation and debridement, and you can primary and close this with and leave some drains. If it's a human bite, you'd want to let it close by secondary intention. So this is a patient of mine who fell while riding a skateboard. And this kid, remarkably, he did not injure his testes. I did an ultrasound just to make sure. He was urinating fine. Fortunately, did not get his posterior urethra or his rectum. And he had no blood in his urine. So I felt confident that there was no injury to the urethra. And he let us sew this up at the bedside, just some primary interrupted sutures. And then testicular trauma, you will expect to see scrotal bruising, swelling. You may have a hematoma. This is usually from sports or athletics. Penetrating trauma, you can see scrotal swelling. A lot of times these testicular injuries are from penetrating scrotal injuries. I've had 2 gunshot wounds that I've taken care of. One of the testicles landed, or one of the bullets landed right in the testicle and it was stuck in there. You want to do an H&P, an ultrasound. If there is a hematocele, then that most likely, there's a 50 to 80% chance that there was a rupture of the tunica albuginea. If you're asked this on a test question, you're going to want to explore. Sometimes if it's a small hematocele, you may be able to watch it conservatively. I typically, in the book answer, will be go explore. So this is a child of mine that I had who was a baseball player, and he was catcher, and he actually had a cup on. He was doing what he was supposed to do, but the ball just hit just right. And he had, here you can see the tunica albuginea with a rupture here. When I explored, this is after I debrided all of this, the nasty seminiferous tubules were black. I debrided all of this and then brought this together and sewed it together. And we were able to save his testicle on that side. So penile trauma, blunt is more common than penetrating. We still do see penile fractures in pediatric world. Most of the time it is still from sex or masturbation. They can have an associated urethral injury. So if you're you have to take them back to the operating room anyway. I usually do a cystoscopy. Oftentimes we'll see pediatric trauma from a circumcision complication. Fortunately, we don't see it very often, but occasionally we see penile amputation or burns to the penis from a circumcision. Hair tie strangulation. So sometimes mom hair gets wrapped around the penis and it can mimic paraphimosis. And then zipper injury is very common, as well as the toilet seat. So this is a 16-year-old patient also of mine who was having intercourse with his girlfriend and had kind of the classic hematoma here in his scrotum. And here's his urethra. The blue loop here is around his urethra, which he was, it was very thin. He didn't have true extravasation, but when I scoped him, but I went ahead and left a catheter in him for a week. But here's one injury through the tunica albuginea on that corpora, and he actually had another one on the other side. It was one of the worst penile fractures I've ever seen. Both of his corpora were involved. And these are just some circumcision issues that we see. This is a plastic, it's called a plastibell, and it's, you put it on and you tie a string, and then the skin necrosis and just the bell falls off. Well, a lot of times they don't fall off, and I had to cut this one off. This is after they performed the dorsal slit, they had actually cut the urethra. So I just let this heal, and actually I did not let them finish the circumcision, and it healed, and we went back for the circumcision later, and this had fortunately healed. This poor guy had his glands completely cut off during a ritual circumcision, but this was the after with it placed back on. This was a combined surgery that my partner did with plastic surgery as well. This here is a penis that he had a circumcision at when he was a newborn, and they injected epinephrine with their lidocaine for his penile block. So we never like to use epinephrine for our penile blocks. And so we put nitro paste on the area, as well as phenylalanine to help negate the epinephrine. And this was already a couple hours after, and then before he went home 2 days later. So the penis is extremely resilient, fortunately. So always get an ultrasound if you're concerned for scrotal testicular injury. Even if it's superficial skin, you're going to sleep better at night knowing that the testes are safe. You'll want to make sure that you clean the wound copiously. Don't assume that the emergency room will, because a lot of times they don't. Even in pediatric patients, always think about penile fractures because it can still happen. And when in doubt, if the pediatricians or obstetricians who are doing the circumcision have any concerns, I tell them to stop. So pediatric trauma is somewhat different than adults, but ultimately you still want to have a timely and accurate diagnosis. Most renal trauma can be managed expectantly and have a high suspicion of bladder neck injuries when you have a pelvic fracture. And oftentimes when we're looking at pelvic fractures, bladder ruptures, multiple organ systems are affected, and even in renal trauma in children. Are there any questions or comments any of you have? I don't know. Let me stop sharing here. And I did not look for any questions here in the chat, but take it. Oh, I'm sorry. What is H&P? History and physical. Does anyone have any questions?
Okay. I would like to thank you, Dr. Heidi, for this bright presentation. Honestly, we don't do much in Haiti in PEDS. We do like some hypospadias repair, some bilateral or chiropexis, and circumcision and hydrocell mostly. But I think I don't know for my colleagues, but I think I learned a lot. And I think this kind of presentation is a good thing for us in Haiti. And I have some questions for you.
Yes.
Talking about the ureter, we don't have a bunch of size of ureteroscope in Haiti. Do you think like a 6 French ureteroscope can be used for kids if I want to do a ureteroscopy? Or do you think I need a smaller one or something like that?
Well, I think, so we have some 4.5 cystoscopes or ureteroscopes, but a lot of ours are 7 French. So I think that's fine. When we suspect a ureteral injury and we do the retrograde, if there's extravasation, I will try just to put a stent up. And then I really won't do a ureteroscopy. I'll leave the stent in for, I don't know, it depends, maybe 4 to 6 weeks. And then what I'll do is I'll take that out. I'll do another retrograde. And if there's no extravasation and it looks healed, I don't do a ureteroscopy at that time. So that's the good thing about trauma in that case. But I do think, because ours is usually a 7 French, and sometimes just with kidney stones in kids, it is a pain because sometimes their ureters just don't accommodate that. And so a lot of times what we'll have to do is stent them and let them passively dilate for a couple of weeks. And then we're able to take our scope up there. So I was going to ask you guys that, do you have a lot of, what size of stents do you guys have available?
We have many sizes. We have 4.5 to 8 French.
Oh, great. Okay.
Because we're doing a lot of laser stone for the ureter and ESWL also. So we have some stents.
Do you have a lot of pediatric stones?
Not that often. Sometimes in my practice, I can find some cases, but most of the time they are adults. Most of the time.
Okay.
And I have another question about the bladder trauma. I see that you didn't mention cystoscopy. It's not useful in this kind of, I know for most of the time you got the blood, gross hematuria, you cannot see, but is there a situation that we can use a cystoscopy? Like to do a cystoscopy to have some information about the trauma.
Sure. For the
bladder injury.
You definitely can. I think that kind of goes, if you're kind of concerned about a urethral and bladder injury, I have found that trying to find the leak with cystoscopy or finding the opening, oftentimes can be hard unless it's really big. But you can certainly see that sometimes. So, you know, I think in the situation, if they're already going to the operating room, I mean, that's kind of the difference with kids. They have to go to sleep so much more than adults. I'm sure you guys do so much more at the bedside.
Exactly.
We're nicer. No, I'm just joking. But for kids, they're usually having to go to sleep because they're not going to sit still. But I certainly think you could always try, especially, you know, if imaging hasn't been sufficient. Obviously, you'd want to be concerned with your irrigation if you are especially concerned about a big intraperitoneal leak because you don't want to play more or something. But no, we certainly would do cystoscopy because if we do think there's a urethral injury or no one can get a catheter in, I always say we'll try one pass, and if we can't do it, then we will scope. And then, of course, look around the bladder if you can and everything like that.
Okay. And I have another question also, again, about the urethral trauma. Because of the blood supply immaturity, do you think if we got a urethral stricture in a kids, in a children, in a child, do you think we can do a urethroplasty on him? Is there any issue? I'm talking about the blood supply, because I know when you're dealing with the kids, the blood supply is a little bit immature. What do you think about that?
You definitely can, and I think with urethral injuries in kids, I think it kind of is very similar to the adult world, where I think especially for proximal urethral injuries, you know, some people say you should just divert and come back later, let things cool down for 6 months. Other camps are saying, no, just go in there and do it right away. It's kind of the same thing with pediatrics. I think I tend to be a little more, try to maybe divert the urine if you can get something across there and then kind of dealing with it later. Fortunately, I don't see a lot of proximal injuries in kids. I will say when I go to Africa through these IVU, this is a problem. I see a lot more injuries in Africa, especially posterior urethral injuries. And a lot of them have already been kind of managed with the suprapubic tube. And so then we'll come in and try to do some repairs. A lot of times I defer it for our reconstructive adult guys because I feel like with posterior urethral injuries, you have maybe one good shot to do it right. And so I always say there are better people than me to do this. And so if the kids are old enough and they're stable and they've got a way to drain their bladder, then I'll either, you know, wait for a reconstructive guy. But I think with the anterior urethral repairs, a lot of times on the kids, especially, if you can get a catheter past it, I think you'll be pretty good with that healing. If not, you can certainly do an anastomosis, like an end-to-end. One thing I would be concerned about, now it'd be rare, if they have had hypospadias repair, because that can affect your blood supply then.
Yes.
So that's always something too, then like, oh, they've had a hypospadias repair and now this. So I would just, and also just counseling that, you know, stricture may, you know, be something that really is something to continue to follow on these patients.
Okay. So it's okay if I want to do a buccal graft, it's okay for the kids to do it.
Yeah, we do that a lot for some of our severe hypospadias.
Okay. And my last question, it's about the meatus injury when the guy was doing the dorsal slit. You said you let it heal. You didn't put any catheter in, or you let it heal by itself?
I just let it heal. I didn't. They wanted to put a stitch in. I said, no, don't do that. We just let it heal like that. And actually, by the time we took him to the operating room 6 months later to do the circumcision, the rest of it, it was actually already nicely healed. So we didn't have to do anything about it. Do you guys do Gomco circumcisions or like bedside or Mogan clamps?
No, we do it like what as you said, like dorsal slit, or sometimes you do a double incision.
Yeah.
I'm not used to use the Gomco clamp. I don't know if Dr. Bluetooth use it.
I always tell the residents when they're doing a dorsal slit to just make sure that their tips are right along the skin so they don't slide into the meatus. Because that's exactly what happened there. And then they just cut it and made it almost epispadic. So I just say, just hug that skin as much as you can. But I know, especially in adults, it's so swollen and it's so messy.
Yeah, because in
Okay.
Haiti, urologists do not use the gumbo usually. Usually, the neonatal circumcision is done by the gynecologist, the obstetrician.
That's
is
how
why-
it is here for the most part too.
Yeah, but yes, we cut. When we do circumcision, we cut.
That's what we like to do too.
Yeah, yes, definitely. And another thing, I have received a lot of cases of meatal stenosis in children that have been circumcised after the birth. And what we noticed is that sometimes the gynecologist, the obstetrician cannot find the right size for the penile size. So when he use a too small a size for the gumco, you know, the pressure of the gumco on the meatus can cause some fibrosis, and later you have this meatal stenosis. And most of the cases of meatal stenosis that I encountered, they were all circumcised right after birth. So this is one of the reasons that made me stop. I used to learn how to do it when I was just when I just finished my residency program. But after encountering so many cases of meatal stenosis, I stopped using the gumco. So I prefer to do I cut, and usually after 3 months, not neonatally.
That's a really interesting, because I always kind of tell people any circumcision can cause meatal stenosis about 10%, I say, in the newborn period. And I think a lot of it too is maybe, the constant rubbing of the diaper on the meatus, and that kind of just constant friction of that diaper rubbing on it. But it's a really good, I don't know the literature well enough to know if they've looked at the difference between Gomco, the Plastibelt, the circumcision like we like, just freehand. Yeah, that's really good.
We don't have. No, they mostly use gumco, but not the Plastibelt.
Now, do you put them asleep at 3 months when you cut?
Yes, I cut after 3 months.
Okay.
Because, yeah, usually the anesthesiologist I work with, she used a codal on it.
Ah, very nice. That's beautiful. That's really nice.
So it's safer than the general for the child, and And I want to thank you, Dr. Heidi, Dr. Stephany, for your wonderful presentation, because the first thing is that we are not to use child trauma, child urogenital trauma. We mostly deal with adult trauma, as Dr. Dwayne just said. So I could notice that it's not that all the guidelines are the same for the pediatric groups, but it's almost the same, right?
It is pretty similar. I think when you talk about guidelines, these are probably the most similar that we have for kids, which is nice. So
yes.
Yeah, a lot of the same.
The question I have, when you do the watchful waiting, I don't know if they say that, they still say that, watchful waiting or active surveillance in the case of renal trauma. You just say when you treat them expectantly. You did not say watchful waiting. I'm an older urologist, so.
You can't say watchful waiting. Everything now is expectant management, because they think you're not going to really watch them. But yes, you like how I have to say the.
I had in the past watchful waiting for renal trauma, and they also used to say that you when you do a watchful waiting or you're treating expectantly, just to say what you just said yourself, you don't have to wait for too long, because after 4 to 5 days, you might have some retroperitoneal fibrosis due to urine and blood extravasation. Is it the same for the child population?
I do. I think so. I think in that one study I talked about from Pittsburgh, I think the latest presentation of watchful waiting was like 11 days. But you're right. Most of the time, if they're going to get symptoms, it's usually fairly quickly.
Okay, good. Thank you. Well, the thing is, you said that you used to go to Africa, so you are accustomed to the bad condition of most of the hospital over there. It's quite the same for us in Haiti. All right, so we don't have available imaging even at the hospital, even at the university hospital, where the conditions are very bad. So when we are dealing with trauma, we have to rely on our sense of, on the history and of the physical examination, and with maybe the blood test. So we rely on the hemoglobin and hematocrit just to know if there is any emergency to go to the OR or to act expectantly. So the thing is, most too often in Haiti, renal trauma are always solved with a nephrectomy. Because usually when we have to go in there, we don't have here of what we are going to find. And when you open the retroperitoneum, you sometimes the bleeding is much more important. So sometimes you have to do emergency nephrectomy. So this is why sometimes you happen to do a nephrectomy that was not necessary because of the limitation of our imaging.
Absolutely. I mean, and we say, oh yes, you can conserve, and there's people in the literature of trying to do partial nephrectomies at the time. There's a lot of nephrectomies going on.
That's it.
It's not a pretty beautiful anatomy picture when you go in there, as you know. So
absolutely.
I think it's quite impressive when they do it. And I know I would feel comfortable if I know they have one other good kidney, struggling and making a much longer surgery than for sure.
Yeah. The thing is, when you open a kidney, when you open an abdomen for kidney trauma, usually there are another trauma injuries in the abdomen also. But sometimes you don't even have time to check on the other kidney to make sure that it is there and in good shape, apparently anyway.
Right.
So sometimes you do the nephrectomy first, and then you check on the other kidney. But fortunately, it is always there. So, so that's the problem with the limitation of our imaging in our hospital. We are very limited if we have to act in an emergency basis.
Okay. So how often do they do CT scans?
We can do a CT scan on a selective basis, not on an emergency basis. Yes.
I want to say something.
Please.
Dr. Brutus, well, I agree a little bit with what you said, but it's not that bad. We can have an ultrasound in the hospital to check if the other kidney is here.
Don't get me wrong. Don't get me wrong. I was talking about having imaging on an emergency basis.
Situation. Okay.
At night, particularly at night.
Okay. At
night. During the day, it's much more easy. It's much easier indeed. But at night, and usually this kind of emergency, you find them at night for some reason in Haiti. I don't know why. During the day, you don't find it. I don't know.
Okay.
It's the same here. Difficult.
And if we have to act in an emergency, it could. Ultrasound is much more available than CT scan in Haiti. Yeah. There is maybe one in the hospital, and I'm not sure. There in the capital city of Port-au-Prince, maybe for what I know, you'll correct me if I'm wrong. We have only one hospital that have on a CT scan. Am I wrong, Yuri? It's
Ben-Amours.
All right.
The one is
right. And we're working on having one at Saint-François.
Yes, we're working on it.
No, yeah.
Working on it, yeah. But it's not a sure thing yet.
Yes.
So that was a very, very interesting presentation, Dr. V. Thank you so much.
It was indeed.
we learned a lot, and well, we hope we cannot hope, but now we can be sure that we can apply some of your recommendation if we have to follow upon a pediatric trauma case. Thank you so very much.
Very, very welcome.
I think she needs a standing ovation.
Great.
Oh, I just want to come visit you guys now. You guys seem like a very fun group. I like it.
Yes, we are.
Yes, we like to tease each other from time to time. You know, urologists relax
I like that.
of individuals and teasing the other. You know, I call him Junior, and he called me Grandpa.
I'd love to
That's
do like hypospadias with you guys. Do you guys see a lot of hypospadias there?
Yes, we have a few cases, and we do some also.
Yuri is the boss of Apospedias. He's very, very good. He impressed me.
That's
He's
awesome.
Yeah, he's very good. He's very good.
Yeah.
Surgical loops?
Oh yes, I have one.
Okay, I was gonna say we need to get you some if you don't, because that would be so hard.
Okay, I have one. I bought it in Miami with I don't remember the company name, but I bought one. I got one.
Very good.
Yeah, I used to do those cases with Dr. DeVries and Dr. Clinton Harrison from Texas. Dr. DeVries, you might know her.
Yeah.
And Dr. Francis Schneck, Dr. Schneck.
So Dr. Fran Schneck was my partner in Pittsburgh. He's the one who got me involved with IVU. And I called him the old man. And he gets
Okay. like Grandpa.
Yes, and I'm gonna have to tell him I talked to you guys tonight.
Okay.
Yeah, thank you so much. Again.
Thank you.
You're very welcome.
And we look forward to have other presentations. This one was very, very profitable. Definitely.
Thank you so much.
Mm-hmm.
All right, you guys have a good night.
Have a good night.
Thank you.
Okay. Thank you so very much. See you next time.
Bye.